Our first speaker is Dr. Elizabeth Kerr. She obtained her PhD in clinical psychology at University of Calgary in 1994. She's practiced in the area of clinical neuropsychology and health psychology at SickKids since 1995. She holds an active scientific appointment with the Division of Neurology at SickKids as an adjunct professor with the Department of Paediatrics at the University of Toronto. She's the head of the Epilepsy Classroom at SickKids and currently provides neuropsychological assessment in the Epilepsy Surgery program. Her major clinical and research activities focus on neurocognitive and behavioral outcomes in medically refractory epilepsy and genetics. She's also extensively involved in healthcare promotion, including applying the WHO definitions for understanding quality of life and health status in child health research. So, Dr. Kerr, the floor is yours.
Good morning. It's my pleasure to be here to talk about cognition and neuroscience in the classroom. And what I'm going to do is I'm going to start by, it needs to be closer? This one? Is that better? Okay. So what I'm going to do is I'm going to start by giving you a little bit of Neuroscience 101 course, linking it to cognition, and then cognition and epilepsy specifically, and followed by some of the strategies that we're using in the epilepsy classroom. So our understanding of cognitive functioning in the brain has evolved substantially with neuroimaging techniques, and it's quite clear that our brain is very much like a roadmap and that different areas control different areas of function. So this is a map of cognitive skills that are associated with different locations of the brain. However, many complex functions rely on the activity of distributed networks or roads, and rather than a single cortical area. So you can see here, I need to get used to this mouse, sorry about that. As an example, the amygdala, which is here in pink, regulates our emotional state. Our hippocampus, here in green, is related to memory. And our prefrontal cortex is like our wise leader. It does planning and reflection and decision making. So I want you to think to a time where you were startled awake by a loud sound. Your amygdala kicks in immediately because it's your security guard. Your heart starts racing. Slowly, your prefrontal cortex says, come on, calm down, listen. You're trying to find out, is there an intruder? Then all of a sudden your hippocampus kicks in and says, you know what, that sounded like the garbage can going over. And together, you come up with the idea that the raccoon's gotten into the garbage, you can clean it up tomorrow and you can go back to sleep. So while particular brain regions are important for specific functions, the capacity of information flow within and between brain regions is also crucial. Our brain is a network of billions of neurons in constant communication, and the axon, which is, sorry, I'm not here. The axon, this part of the neuron, is the main vehicle for transporting information. So a car is moving from the cell body down the axon to the terminal buttons where there's synapse, and there's a release of information using a neurotransmitter to the dendrites of the adjacent neuron. The axon, in blue here, is covered in white matter, and white matter is really a protein sheet which insulates the axon, and it's really related to the speed of which information can flow between brain regions. So it's really important for networks in the brain, and other skills that are related to the efficiency of the network include executive functions, so planning and the coordination of different skills in our brain, and the ability to navigate space. So structure really is function. There's a direct link between the structure in your brain and what you're able to do. And just like a road, we know what happens when the road gets clogged or when there's a pothole in the road. Similarly, it happens in the brain. So when there's interference in or damage to the networks, effective communication between different brain regions is prevented. So using white matter dysfunction as an example, there are many different diseases in childhood that are related to white matter dysfunction. Autism spectrum disorder has been related to white matter. Children who are born extremely prematurely have white matter disease. Different metabolic diseases such as PKU can be related to white matter disease. And then there's a link to cognitive functions that may be impaired. And the degree on which this pattern will show up depends on the degree of white matter involvement. So the message here is that there's something going on in the brain that leads to cognitive behavioral patterns, which has implications for education. I'm going to turn over to epilepsy now. Epilepsy is one of the most common neurological disorders in childhood. It's characterized by spontaneous, unprovoked, recurrent seizures. And a seizure is really the symptom or the behavior. Typically, we can see that outward sign, but not always. What's happening, though, is there's an electrical event in the brain where there's a production of sustained, synchronized, abnormal firing of neurons. So we saw that network of neurons in a typically the brain. There was a firing all the time, but in epilepsy, it's an abnormal firing of neurons. There's an overexcitation. And the neurologists and neurophysiologists can look at seizures by using electrodes on the scalp of the brain, and then they're able to interpret the pattern. Sometimes the medical teams need more information, and so the electrodes are in a much tighter grid formation, and the neurosurgeon can actually remove the skull and put the electrodes directly on the surface of the brain. And you're actually going to see this grid on the direct surface of the brain and see somebody have their seizures. So if you're sensitive, just turn your eyes for a few moments. Let's see if I can get this to go. All right. So the electrodes are picking up the electricity from this boy's brain, and an amazing neurologist at SickKids was able to interpret it to make it into lights. This isn't a seizure activity, it's still abnormal firing of neurons. It's called interictal discharge. You or I wouldn't be experiencing that blue bubbling, but you can see how it's recruiting more and more of the brain. There he's had his seizure, he wakes up, he can feel his arm because where the seizure is happening is where you feel the sensory area of your brain. It ends up incorporating the motor strip. He's asking for medication to stop the seizure. You can see how it's spreading further in the brain, and then it ends up going to the other side. Just move to that slide. The reason I presented that is I really wanted you to see the link that structure is function. You can't see that and not know that the cognitive processes are going to be interrupted. Epilepsy is far more than a seizure disorder. Children consistently have much higher rates of cognitive, behavioral, and psychosocial difficulties than children with other chronic illnesses such as asthma or peers in general. The rate of academic difficulties is as high as 50%. And these issues are of critical concern because they form the basis of long-term educational, vocational, and interpersonal functioning. There's lots of different reasons why these difficulties present. I think a lot of people contributed to psychosocial factors, sorry about that. And certainly an individual is dealing with epilepsy, they may be absent from school because of the number of seizures that they're having, but I would consider that a minor player. A bigger player is neuropathology. So whatever's happening at the neuronal structure to cause seizures in the first place is also contributing to the cognitive, behavioral, and social difficulties. The seizures themselves also contribute. So there's lots of research that shows that seizures are damaging to the brain. The interictal discharge, that blue bubbling that you saw, is associated with transient cognitive impairment, slow processing of information, poor attention, and so forth. There's also research that shows that when an individual has more frequent seizures, so when they have an earlier age of onset and when they've had a longer duration of seizures, they're more likely to experience these types of difficulties. And then the final player is anticonvulsant medications. They all have side effects. But on the balance, having your seizures and your interictal discharge controlled is better than the side effects of medications. There's no learning-specific profile or learning profile with epilepsy, but there's many frequently reported cognitive issues. So in terms of speed of processing, we see difficulties with slow or inconsistency of processing speed and variable responding. In terms of attention, we see difficulties with sustained attention, and that's the ability to stay focused for a long period of time, particularly if something is boring or mundane. And most kids would tell you that school or homework particularly is boring. They're tired. Video games and televisions, not good indications of sustained attention. Over a third of individuals with epilepsy meet criteria for attention deficit hyperactivity disorder, and we know that ADHD in and of itself is related to higher rates of learning disabilities. In terms of memory, many individuals have difficulty consolidating, retaining, and transferring newly learned information, and working memory actually is related to each of these other skills, and this is another area of concern. So working memory really acts over a few seconds. It allows a person to hold, process, and manipulate information in mind or online in order to complete complex cognitive tasks such as learning, reasoning, planning, and organizing. It's considered to be vital to a child's daily adaptive functioning, And there's a study that shows that working memory at age 5 is the best predictor of academic success at age 11 over and above intellectual functioning. So when you consider the number of cognitive issues associated with this particular neurodevelopmental condition, I think it's clear to see that even major scientific breakthroughs in our understanding of epilepsy or the treatments to improve seizure outcomes are unlikely to resolve the multitude of health challenges related to this condition. And I suspect that's true for other neurodevelopmental conditions as well. So we really need to come up with alternative strategies to empower patients to improve their health outcomes and their quality of life. For children, school education and learning represent the primary interactive biopsychosocial components associated with their health outcomes. So understanding the implications of the association between neuroscience and cognition is a critical first step towards supporting young students with neurodevelopmental conditions at school. Within the Epilepsy Classroom, our primary objective is to resolve or revolutionize education for students with ongoing epilepsy who have learning difficulties. And in order to do that, we're trying to assist them to overcome or compensate for the personal learning challenges and be able to perform as independently as possible in terms of their academic success. We really do believe that cognition and psychosocial well-being go hand in hand. So part of our programming is also directed towards building self-confidence and resilience and strengthening self-advocacy skills. It is a Section 23 program or a treatment program within the Ministry of Education of Ontario. It's an initiative as a Centre for Brain and Mental Health at SickKids, and we partner with the Toronto District School Board. In order to meet our objectives, we have a multidisciplinary team who performs interacts very well to do a circle of care for each child and family. We have a special education teacher and an educational assistant from the Toronto District School Board, along with an academic assistant or a child youth worker in the classroom daily with 8 students. We have coordinated input from a social worker and a neuropsychologist on a weekly basis. A developmental pediatrician and his fellows do an assessment in the fall with each student and their family, and then may be involved a longer term. So there is a much higher incidence of autism spectrum disorder in epilepsy, and so it may be that we need to have a full assessment for that. I've already mentioned the association with attention difficulties, so they may do a stimulant trial to see if this child improves. We also have an occupational therapist, and currently what she's doing is she's running 2 6-week groups focusing on sensory issue for individuals with epilepsy. We're very fortunate that we have a few consultant staff that we can recruit in on a need-be basis. We do have the potential to continuously monitor brainwave to determine whether seizures or the interictal discharges are interfering with learning. And so when we put all of these pieces together, we've identified the interests, strengths, and needs of each student, and we can develop a plan of care accordingly. The research shows that accepting environments, joyful experience, and explicit instruction are essential for students with even mild cognitive weaknesses in order to learn. Within our classroom, we're committed to using research-based, scientifically validated approaches to explicit instruction. So we're not just picking out of a hat going, well, I think this might work for this child, and I think this might work. We don't change our program every year. We're really based on the research and it being scientifically validated, and all the tools that we're using are commercially available. We're also committed to evaluating our students' outcome to ensure that it's really working with our population. So our main mode of instruction is direct instruction, and it has a curriculum that adheres to some components that we believe address the core cognitive processing weaknesses that we see in epilepsy. So there's response cues to help with the sustained attention. There's scripted presentation and guided practice to aid with the slow processing speed. There's cumulative learning to help with the difficulty in transferring newly learned information. We always start teaching at a child's functional level rather than the current grade level, so that they're building a very strong foundation in the skills, and we expect skill mastery before they move up to the next level. So this is looking at the effect of direct instruction on academic achievement in a group of our students, 35 of our students. This is just one term, it's 12 weeks. These scores on the side are standard scores, and a standard score rates an individual, or in this case a group, relative to typically developing peers. A standard score of 90 falls at the lower end of the average range, or the 25th percentile. So all these scores are below average. The standard score of 80 is at the 9th percentile, and this is about where their intellectual functioning is. So what you can see is that with one term of intervention of direct instruction, their literacy skills and their numeracy skills are almost all about their intellectual functioning. The other thing I want to point out is their performance is being compared to their typically developing peers. So they've made a gain in their standard score, but their typically developing peers are also making gains. So these kids haven't just stayed on their own trajectory, they've actually jumped the track and they've bridged the gap between themselves and their typically developing peers. So that's significant in itself, but when we look at the statistics, it's also significant in all areas. We augment our curriculum using learning to learn strategies and self-regulation strategies, and the research shows that these provide benefits beyond those gained through explicit instruction alone. We do have technology to facilitate on-task behavior, that's sustained attention issue, but also to give students access to the curriculum that was previously not available to them. So I'll just point out with assisted technology for the computers, that is individualized, so we look at the child's strengths and where their needs are, and they get training on the technology that's going to benefit them. So for example, a very weak speller or somebody with severe fine motor difficulties, which in epilepsy happens quite frequently, would learn voice-to-text software. In general, the research shows that for struggling learners, assisted technology leads to improvement in academic outcomes as well as students' attitudes. We're also doing a working memory intervention, and this is a research project in the classroom, and it's also with epilepsy in general. We're targeting working memory because that's a core processing weaknesses that we see in epilepsy, but it conceivably has far-reaching benefits in terms of improving cognitive, academic, and adaptive functioning. The method that we're using is CogMed. It was scientifically validated with individuals with ADHD, and it became commercially available in 2010. Unfortunately, with CogMed and other working memory interventions, looking at it with non-ADHD neurological conditions is relatively scarce, so that's why we're researching it. Although our kids have difficulties with attention, the underlying neuronal substrates causing the difficulties are not likely the same, and so the response to treatment is likely different as well. So this is just looking at two measures of outcomes. On this side, we have individuals who did not receive any intervention. They were assessed 6 to 7 weeks apart, and you can see that the performance remains in the low average range and there's no significant change. These are the individuals who received the intervention. It was a 5-week intervention. They were also assessed 6 to 7 weeks apart, and they showed significant improvement in 2 untrained tasks of working memory, so much so that the performance has changed from the low average range to the average range. We do have other outcome measures, but I'm not going to present them here due to the interest of time. The Epilepsy Classroom is a transformative learning environment where students are provided with the right tools to succeed and thrive, and we believe that it may be pivotal in altering their academic and social developmental trajectories. In summary, neurobiology, cognitive abilities and psychosocial issues, and the environment influence academic success. And we have the opportunity to adjust our environment to influence cognitive abilities. We're probably not going to change the neurobiology though. I thank you for your attention, and I can open the floor to questions.
Do you see any applicable transference from what you've done in your classroom into a regular TDSB classroom when you have a lower proportion of children with cognitive disabilities?
Well, I think first of all, just understanding where the weaknesses are in any type of neurodevelopmental conditions are really important, because there are strategies that can be used in a classroom to allow a chance for a child to respond. So if you're slow processing information, and in doing assessments with kids with epilepsy, I ask a question and it doesn't look like they're coming up with an answer, and they may come up with a beautiful answer. It's just taken them 4 times as long to come up with the answer. So if a child puts up their hand and then doesn't say anything right away, you have to have the patience to be able to respond. But the other thing is, in terms of some of the instruction, is that I think you can see when a child is available and when they're not available. So there are different cues that you can give a child within a classroom. So we're using response cues. So there might be a cue that a teacher can use that child will respond to. So there's just little strategies. I think in terms of doing direct instruction though, that you're really looking at the special education resource teacher and having resource time in order to go through the curriculum that's needed in that area. But all kids could benefit from learning to learn strategies, so that could just be part of the curriculum.
Yeah, for the ECEs in the room or educators in the room, I think I would like to hear a little bit of your perspective as well, to see what your experience is with kids with cognitive disabilities and maybe some of the comparative experiences, because we want to make sure that we can bridge these gaps. What happens at the Epilepsy Classroom, I mean, it's a very intensive program, highly supervised, but within the TDSB environment we may not have the same degree of resources. Do you have any specific questions that you would like to ask Dr. Kerr with regard to some of the scalable issues, the issues of resources, and maybe things that you can look at for hints at your level of deployment that she can help you with?
Maybe different assessment tools that we could use. The tools that they give us right now aren't really geared towards children with those needs, so maybe if they change those assessment tools like TDSB coming from the top, that might help us out in the classroom.
So I do think that for most children with neurodevelopmental issues, one of the first systems that gets impacted is attention. So having some way to assess attention in the classroom is probably a good thing to do. I do know that I work with many different boards, and it seems that the assessment tools that are being used in the classroom seem to change on a yearly basis. I would be looking at tools that give you sort of grade equivalents to see where kids are at, so that the child is being taught at that level as opposed to being taught at, knowing somebody's in a low average range isn't really meaningful to education. It's not really meaningful to a parent. You need to give it in terms of, well, what's the age equivalent or what's the grade equivalent, so you know where to gear your instruction to.
Research, do you think can inform education in general, which is committed, it seems, for economic reasons, to a one-size-fits-all? Don't we find that most children have different learning styles, different abilities, whether they're disease, quote unquote, present? I mean, ADHD is probably the most highly medicated disease or condition with children now. And it seems to me that so many of these difficulties are a result of the direction that education is taken based on standardized tests, very rigid approaches to evaluating teacher performance and score performance. It seems to me that this kind of research, if generalized across the student populations, can liberate us in a way that will impact all children, not just epileptics.
I think you're probably true, very true. One of the things, and I had the pleasure of listening to a presentation last month, is talking about when you focus just on the outcomes, so where are you in reading, where are you in spelling, and you don't look at the process behind how you get there, and really trying to teach critical thinking. So that's one of the things that I think everybody could benefit from, is that those learning to learn and the critical thinking, so how you apply the knowledge that you've actually gained rather than focusing on the outcome being the knowledge and getting that mark for that. There certainly are very different learning styles, and we really do teach towards the mean. So regardless of who you are, when you have a neurodevelopmental condition, you have that learning style and you have some cognitive deficits on top of that. So it's a little bit more complex. But I do believe that there probably should be a shift in education away from mark focused to process focused.
Just a question, I guess, about the long-term outcomes. So if they're part of the program or if they're part of an intervention that's 5 weeks and they're using the resources that are easily accessible in the Epilepsy Classroom, what are the outcomes like if they do transition to a TDSB classroom? Or like if they have a 5-month intervention and there's a significant difference, or a 5-week intervention, what happens at like 6 months, a year, or like 5 years afterwards?
So our classroom is actually a full year program. It used to be a 1-term program, and what we realized is that there was a change in confidence in kids pretty much at about the 4-month mark, and they were you can see where their skills were in terms of their academic success, and parents would say, they want to read at home, they're happier, and so you were sending them back and transitioning them back maybe mid-year when there aren't programs available or resources available. and without a strong foundation. So we moved to a full year program so that there was a better transition time, that they were able to get a stronger foundation in their skills, to have stronger self-confidence and so forth. So we follow these kids up now a year post to look at see where their gains are. We actually do contact the families and the school that they've transitioned to in the fall to see how they're settling in. We do have a transition meeting in June so that we have the home school come in and talk about the whole child, because they've had many different assessments, so we're really understanding where their needs are, where their strengths are, what strategies worked in the classroom, what strategies didn't work in the classroom, and usually the home school comes up with ideas of resources that they might be able to provide that student. Some of our students go back into a regular classroom with special education resource support or with an educational assistant. Some of our kids actually need to go to a homeschool classroom or some other alternative, so they don't always transition right out. The biggest thing that I can see, and the kids come back year after year after year to come visit the classroom, is that what change it made for them in terms of their self-confidence and their belief in themselves. So whatever placement they get into, they're just more equipped to deal with whatever's there. Are they going to continue to have learning challenges? Absolutely. The working memory intervention, which is 5 weeks, we are looking at it 3 months out to see if the gains are maintained. I don't know if this is the be-all, end-all program for this group. There's showing lots of benefits, but there's also a number of problems in running the program. So we are looking into alternatives for that. But we are trying to do longer term follow-up. Thank you very much.
Thank you very much.